Hey, good morning. I'm hoping that I can keep this at 15 minutes because that is the amount of time that I have, apparently. So, we're going to talk today about interprofessional collaborative practice and care coordination across settings. So, when you think of being a nurse, a lot of you think acute care in the hospital setting, but there's so much more to nursing, which is why we have a million different things that we can do in this profession. So, let's get started with community health. So, community health, our goals are set forward by Healthy People 2030, and those goals get set way before 2030 gets here. Like we've been talking about these goals for before 2020 arrived. So our public health community gets together and sets what those goals are going to look like. So if you click on this link, you can see the mission and vision of Healthy People and the goals. Underneath that, you see Johns Hopkins Hospital Community Health Needs Assessment. That's a nice to know, but I would really become familiar with your Healthy People goals. And then we look at, when you look under the socioeconomic needs and the direct health needs, those are things that we are constantly looking at. So depending on where you're located is what you decide your goals are going to be or which ones you're going to pick for your community. So perhaps unemployment's really high in your area, or you have a lot of crime, or you have a lot more homelessness than we had in the past. So you look at those and you set goals for your community. Or perhaps you live in an area of the city, for example, like Sun City or East Mesa, where you have a lot of an older population with many chronic health diseases. So those are going to be your focus. Uninsured and underinsured, I believe that should be a focus of everyone. So anyway, you do that assessment of your community and determine your goals. Then you have community-based healthcare. Community-based healthcare is provided to people in the community in which you're working. So if you are working in community health, it's important that you have a good set of skills. So going out as a new grad, they're hiring new grads to do that. But I think it's important to get a good foundation of what the treatment options are and what the assessments look like for people with different disease processes, so that when you're out in the community by yourself, you can look at it and say, oh, this is what's happening and this is what I need to do. So our community-based healthcare is probably our fastest growing area. Because if you think about it, our population is aging. They come into the hospital with an acute problem. We take care of them, and then they need to leave. We don't keep them forever. They're now stable, so they're getting discharged. If they can go home, they go home. If they need to go to skilled nursing for rehab, that's where they go. But they also don't stay there forever. So once they're back in the community, community-based healthcare nurses or home health goes out and helps to educate the family or the patient in how to manage their care or how to promote better outcomes. So it's probably, I would say, the fastest growing area in our healthcare. So I mentioned this earlier that a community-based nurse needs to have knowledge and skills. So you need to have some experience. You need to be independent in making decisions because a lot of times you are the eyes and the ears for your patient. That does not mean you don't have resources. I work currently for Hospice of the Valley after hours going out to visit patients. So if I don't know what I'm looking at or I'm not sure what to do, I have a bunch of people I could call. We have a phone center and everybody there's a nurse. So I can go, hey, this is what I'm seeing. I haven't seen it. So it's not that you don't have a team available to help you. It's that you need to kind of know what you're seeing. And we have to be accountable to goals and documentation. So the roles of our community-based nurse are not a lot different than those that work in the hospital setting. We are an advocate for our patient population, and I feel like that's one of the best and most important things that we do for our patients. We help coordinate their care. So when I say we coordinate their care, we might need to contact a doctor. We might need to contact a specialist. We might need to call an ambulance. We might need a social worker to come in, or maybe they're having some spiritual issues and we call in a chaplain. So there's a lot of different coordination that can happen when we're providing services in the community. Then a big, huge part of it is educating your family and your patient on what they're seeing or what their disease process is and what they need to do to either slow the progression or reverse the progression. So continuity of care is the goal of our community health. So when you're leaving the hospital, do you think everyone is always like, I love it when patients say, oh, they're better, they're going home. A lot of times they are not better. They're not ready to really, they're not strong. They're not going to get out and drive the next day. They're not walking around ready to go. So we got them stable, but now they're going home and they're weak. We are going to ensure that there's a transition from that acute care setting back home or to the skilled nursing facility. How do we do that? Through communication. So you're going to learn a lot more about SBAR or ISBARQ. This is what it stands for. I don't really use the ISBARQ method, but I do, but we don't call it that. So here's who I am. Hey, I'm Marcel. I work on the 7th floor at Baywood, and I have a patient who recently suffered a stroke and they have left-sided deficits. Their background is they had a history of atrial fibrillation and high blood pressure, and now we have them ready to go to skilled nursing for 3 weeks of rehabilitation. Most recent set of vitals is this. Last bowel movement was yesterday. They're urinating just fine. They had, 1,200 mLs output. And then what are you recommending for treatment? You're recommending 3 weeks of skilled rehabilitation services. And then what questions do you have? And then we answer them. We make sure we give the information necessary so that there's not a lapse in the care. Part of that would also be going over what their current medications are. Okay, so that's just a quick example, and obviously there's way more to it, but that's a quick example of handoff report to the next area that patient's going to be cared in. If they're going home, then that report is pretty much given to the patient's family if they are not going home with home health. So interprofessional collaborative practice. That is basically, for example, with hospice. In hospice, we have an interprofessional collaborative practice. So that practice could be the doctor who oversees the care of the hospice patient. It is the nurse case manager who oversees weekly visits and assesses the patient and determines what their needs are. And then we have a medical social worker who comes in and talks with the family about resources available to them in the community. And then the chaplain for spiritual distress, or, they just are very religious and want somebody to come in and give them communion on Sundays. And lay people can be part of this too. Even though it says interprofessional, you can have volunteers that come in and sit with your patients because maybe they don't have family. So that's interprofessional collaboration. And you're going to need to make sure you can identify what is your role as a skilled nurse, and then what is the role of all of those people that collaborate with you, because we want to do what we're supposed to do and let the people that do their job, but get them engaged and keep them up to speed by giving them report on the patient and what their needs are. So I'm not sure what happened here and why there's some stuff showing there. We're going to ignore that that's there. So care coordination. You have the transition of care. So whether the patient is in the hospital and you're giving a report from day nurse to night nurse to day nurse, that's one. Or it could be transition of care, patients leaving hospital, going to skilled nursing. Patients got home health currently, but now they've decided to go to hospice. So anytime you're changing care or level of care, you want to make sure you're giving a great report so that nothing drops through the cracks in the care of that patient. And then, I don't know what this says, central responsibility of all healthcare professionals and especially nurses. Okay. Obviously, we want to link our patients with resources in the community, improve information and communication, and reduce fragmentation and duplication. So fragmentation is like you got too many people involved and too many fingers in the pie. So I'm frustrated because I try to call who I think I'm supposed to call as the patient's wife. And they're like, oh, no, that's not me. You need to call this person. So I spend 4 hours on the phone. So we want to reduce that fragmentation. We want to have somebody who's managing that case. And then duplication of services. We want to be good stewards of Medicare or the insurance or the private pay person that's paying out of pocket. You don't want to duplicate, like maybe I need to have an MRI done, but they just had an MRI done last week. If I don't know that and I do another one, now they have to pay for 2 MRIs, or maybe they won't pay for 2 MRIs, and now they're coming after the patient for reimbursement. So we need to make sure we're communicating. And then here is your care coordination ring. This is a nice little visual. All of the things that happen and all of the people involved. And then you have your care coordination. So your care coordination a lot of times is the nurse, but you're coordinating with other areas. So you have the nurse, the social worker, the medical professionals all involved in the care. And then you're always keeping in mind your person-centered care. So the patient and family, what do they want? Because that's really what matters. And then we have our perspective. So maybe what they want doesn't mesh with what we think they should have. We really need to still consider what they want, and we can educate them on what we think might be a better outcome, but you got to be careful with that because we're always going to honor what the patient and family are wanting. So we're going to meet the patient's needs and preferences. And I'm at 12 minutes. Where am I on this recording? All right, role of the nurse and patient navigator. So the navigator, just what it sounds like. What's happening? Why are we not getting the treatments that we need? Maybe I can't get into this doctor and I really need to. So they facilitate that. It's a clinically trained nurse and they're a central point of contact for the patient. So now, or for the patient care, everybody goes through that one person and they coordinate it like like a conductor of an orchestra. And then that's the nurse navigator. Patient navigator can be a nurse, a social worker, or a lay person. And they're focusing on support aspects of care. All right, so your vulnerable population. This goes back to your People 2030 goals, healthy people. Your people with disabilities or multiple chronic conditions, mental illness or substance use, cultural, racial, and ethnic minorities, people experiencing poverty in rural and urban areas. So poverty in a rural area, you add that they don't have resources for medical care in rural areas like we do in urban areas. So there's a huge disparity just without adding poverty in. Those who are homeless and undocumented immigrants, those are our vulnerable populations. Admission to ambulatory care setting, that's when they're going to skilled nursing. Okay, so that's when they're coming in, maybe like I'm going in for an endoscopy, that's a same day surgical. I got to make sure that I've been screened and that I know I can't take a blood thinner, and I'm going to be taking some strong medications. I need somebody to drive me home. I can't drive for 24 hours, etc. It's basically, you got to know what your restrictions are. And then admission to the hospital. The biggest part right here, I feel like, is the med reconciliation. Got to get that done. Because if somebody has seizures, let's just a great example. If I don't do that med reconciliation, they don't get their seizure meds. Now they're having a seizure. We want to avoid that. So it's important to get that done early. And then here's all the information you need to get on an admission sheet, no matter what their type of care is. All of that's super important. So look that over. We're running out of time. Transfer within and between healthcare settings. We already talked about that. Discharge planning starts when you are admitted or even before. So we need to evaluate what resources are available for them, implement and coordinate the care, assess the environment they're going home to. Is it going to meet their needs? an amount of time, so I'm going to stop and I'll start a new one.